Good evening, everyone. I am Sumit Madan from Zydus. We are privileged to collaborate with Mumbai Hematology Group for this academic initiative on myeloma. At the outset, we thank MHG for providing us this wonderful opportunity. I also take this opportunity to welcome all respected faculties, delegates, and our international speaker, Dr. Binod, for today's webinar. I extend a warm welcome to Professor Dr. B Agarwal. Sir has been working relentlessly through numerous initiatives to improve hematology care in India. With this endeavor, he continues to inspire many young clinicians across India. He is an institution in himself. I take this opportunity to introduce Sir. Sir is professor and head of department at Hematology Department, Bombay Hospital, Mumbai. Sir is also associated as senior consultant at Breach Candy Hospital and Leelavati Hospital. With this, I welcome Sir to take this evening further. Over to you, Sir.
Thank you, Mr. Sumit Madan, for introducing this meeting and introducing me. Thanks for the kind words. I'll just share my screen. Good evening, friends. This evening, our guest speaker is Dr. Binod Dhakal from Milwaukee, US. He'll be speaking to us on MRD in myeloma. Is it ready for the prime time? In a short span of 6 months, this is the second time he'll be addressing us, and I'm extremely grateful to him for sparing his time and being so kind to us to educate us in this country and surrounding. Over 500 delegates have registered. Large number of you have already logged in. Many of you heard him last time, were very impressed and demanded to hear more from him, and today's lecture is a result of that. This webinar is brought to you as usual by Mumbai Hematology Group. It is supported by Zydus, managed by Mice Ideas. I thank Mr. Ashish Kumar and his team from Zydus, Rajesh Kalpesh and the team from Mice Ideas, Executive Committee of Mumbai Hematology Group, who have been very kind to me. Our guest speaker this evening, Dr. Binod Dhakal from Milwaukee, all our discussants who are themselves eminent hematologists or medical oncologists from the country, you participants for sparing your Saturday evening for the academics. Our discussants today include Dr. P.P. Abdul Shahid, is medical oncologist at KIMS Cancer Center, Trivandrum. Dr. Ayan Bhattacharya is director and clinical oncologist, Regional Cancer Center, Kuch Bihar, West Bengal. Dr. Akshay Shah is director, Conquer Cancer Daycare Center, Nanavati Hospital, Rahija Hospital, Global Hospital, Mumbai. Dr. Bharat Patodia, medical oncologist at AIG Hospitals, Hyderabad. Dr. Alkesh Patel, oncologist, Ramanbai Patel College of Pharmacy, Charuset, Anand. Dr. Ramesh B, Department of Hematology, Sir Gangaram Hospital, New Delhi. Dr. Kunal Goyal, Institute of Hematology and Transfusion Medicine, Medical College and Hospital, Kolkata. And Dr. Giri Punja from Department of Hematology, Manipal Hospital, Bangalore. It's my privilege again to introduce this evening Dr. Binod Dhakal. He's MD MS. Is Associate Professor of Medicine, Division of Hematology and Oncology, Medical College of Wisconsin at Milwaukee, US. He specialized in multiple myeloma and other plasma cell disorders. He graduated from Manipal College of Medical Sciences, Pokhara, Nepal in 2004. He completed internal medicine residency at St. Francis Hospital, Evanston, Illinois, and did a fellowship in hematology oncology at the Medical College of Wisconsin, where he now serves as a chief fellow. He has authored numerous publications, including journal articles, meeting abstracts, and book chapters. He's obtained his master's degree in clinical and translational science. His current research areas include myeloma immunotherapy, focusing on the clinical and translational aspects, high-risk myeloma, and myeloma kidney disease. He's actively involved in several investigator-initiated and industry-sponsored clinical trials for patients of multiple myeloma. He holds membership of American Society of Hematology. It's my proud privilege to invite him to deliver his talk on MRD in myeloma. Is it ready for the prime time? Thank you, and over to you, sir.
Thank you, Dr. Agarwal, and good evening, everyone. It's my privilege to give a lecture, another lecture in 6 months, and I hope this will be exciting and stimulate the discussion this time as well. So I'm going to share my slide first here. Can you see it? Okay, the slides?
Yes.
All right, excellent. So the topic I'm going to talk about is MRD in multiple myeloma, and is it ready for prime time? As you know, MRD is being investigated or being included as a part of the clinical endpoint in several diseases, and myeloma is not an exception. And we have several trials that looked at MRD as one of the endpoint, but whether it's ready for prime time or no, we're going to discuss that in the next 30 to 40 minutes. So before that, I would like to start this presentation with a case. So this is a patient of mine, and we can discuss that in the time of discussion what we did for the patient. But just to start up to set the stage, I would like to start with the case. So this is a patient of mine, a 53-year-old female, healthy female. She was diagnosed with IgG kappa multiple myeloma, ISS stage 2, RISS stage 2. She also had MYC positive. She was diagnosed in February 2018, and she presented with diffuse pain at the time. She underwent induction with the VRD for 4 cycles, and that resulted in 49% reduction in M protein, so less than partial response. Then she received a Kyprolis-based regimen, KRD, for 2 cycles and achieved a partial response. She then underwent autologous stem cell transplantation with MEL200 on October of 2018. Disease evaluation around day 80 showed that she was in a very good partial response, so she definitely deepened the response, but she was also MRD negative by institutional flow. So we had the institutional flow that we routinely do the MRD testing in those patients after transplant with the 10 to the power minus 4 sensitivity. And the patient wants to know what is the long-term prognosis with this response. So the options that I had at the time was obtain MRD by NGS, obtain MRD by next-gen flow, obtain MRD by both next-gen flow or NGS, but along with the PET-CT, and start maintenance on and off trial. So we'll talk about this case during the time of discussing. So what is minimal residual disease? As the technology has advanced in monitoring and in assessing the disease response, in myeloma, we have been lucky to monitor this disease at a deeper level with the development of MRD technology. So if you look at the myeloma disease burden per se, myeloma disease burden before and after therapy can be illustrated with this iceberg model. The achievement of complete response is represented by the disappearance of of measurable disease above the surface, but it is important to note that there is a significant amount of disease below the surface as well. And several studies that has been done in the last several years have shown that if you have MRD negativity, that means no disease below this level, and that portends to a very good outcome. Or in other words, MRD negativity can be considered as a very good prognostic marker. But what about those diseases that are outside the bone marrow and you are MRD negative, but still could be able to detect the disease outside the bone marrow? What that portends? So MRD negativity or MRD status at the time of after the treatment definitely portends a very good prognostic marker, but there are several unanswered questions at this time, and which is here listed here on the right side. And these are a lot of research questions that is being investigated, and we'll discuss how far we have come in those answering those questions. For example, how good is MRD in predicting responses? Why some MRD positive patients do not progress? How frequently we should evaluate the MRD, how to improve the sensitivity, and how to incorporate imaging to MRD. So there are several research questions right now being investigated, and we'll discuss that as well. Now, the prognostic value of MRD has been very firmly established with several studies, but mainly after this meta-analysis that was done by Dr. Munsi. So this meta-analysis included all eligible studies that included MRD and the impact of the MRD on PFS and OS in multiple myeloma, and included studies that had about 20 patients or more, and assessed that as one of the endpoint. Now, with that search, they were able to find out about 405 studies. And for this particular analysis, the total of 21 studies made the eligibility. And if you can look at on the right side, this is the impact of the MRD by any methods and after treatment in newly diagnosed multiple myeloma, including the patients who had a stem cell transplant. So there are about 12 studies, 14 studies for the PFS, and you can see very clearly that the achievement of MRD is significantly associated with the superior progression-free survival based on the hazard ratio that you can that is given here. And whatever the impact of MRD on overall survival. And there are about 12 studies that looked at the impact of MRD in the overall survival. And as shown here in the graph, the achievement of MRD negativity is also associated with the significant improvement in overall survival. So this study established the prognostic value of MRD in predicting both the progression-free survival and overall survival in myeloma. At the same time, there were another meta-analysis done, again, including all the recent studies and by Dr. Langren, and that included 4 studies and looked at the impact of the MRD by any methods and by any sensitivity level, and looked at the impact on both progression-free survival and overall survival. Similarly to the previous study, as shown here, the impact of the MRD is very clearly shown in predicting the superior progression-free survival and overall survival as well. So based on these 2 important meta-analyses and several other studies, the field is very well settled in saying that MRD is a very good prognostic marker in multiple myeloma. Now, before we go on to the depth of MRD and how to assess that, I would just like to briefly discuss the level of sensitivity in myeloma when you monitor the disease. As you all know, in myeloma, the disease is monitored by different ways, and we are very lucky to have the very oldest biomarker in myeloma with the use of electrophoresis immunofixation and lately serum-free light chains and all those stuff. So if you look at that, the level of detection of those plasma cells or the level of sensitivity is given here. For example, if you detect the protein by immunofixation and serum-free light chain, you are detecting 1 plasma cell in about 1,000 to about up to 1,000 cells. But that sensitivity will go down or will increase as you start using more recent technology. For example, the patient that I described had about 6-color flow cytometry, and that had a sensitivity of detecting at 10 to the power minus 4 level, so 1 in about 10,000 cells. But the further there are more advanced technology. For example, 8 to 10 color flow cytometry. For example, next generation flow cytometry can detect the cells up to 1 million cells. Similarly, the next gen sequencing, which is the MRD that has been approved by FDA here in the US, that has the ability to detect the cells of 1 cells in about 1 million cells as well. In myeloma, not only this is important, but at the same time, imaging is also important. So if you do the functional imaging like a PET scan, you should be able to detect the lesions of 1.5 to 1 centimeter size and can look at the disease status and the response as well. So this will be important to find out what kind of technology that should be used for our patients and what is the best MRD assay that needs to be that has to be incorporated in monitoring the response. So at this current time, there are 3 ways that you can monitor the MRD or minimal residual disease in myeloma. And this is all shown here, the pros and cons of these available techniques. For example, the most widely used is the next generation flow cytometry or multicolor flow cytometry. And the one that is approved in the US is using the VDJ sequencing or next gen sequencing of the immunoglobulin gene, hemoglobin chain. And the other one that we can also do is ASO-qPCR, which is a little bit cumbersome because you have to look at the primer for each patient, and then you have to monitor that over time. So if you look at the pros and cons, for example, for both ASO-qPCR and the next-gen sequencing, you need the baseline sample. So baseline sample has to be there. But in case of flow-based MRD assay, you don't need the baseline sample. The sample requirements for both genomic way to look at the MRD, you need less number of cells, but in flow, you need a pretty decent number of cells. In terms of the sample processing, you need the fresh sample for the flow, but both fresh and stored can be used for the gene sequencing. So this can be important to look at how to monitor these patients. Doing what technique is going to be important. The sensitivity is for ASO PCR, the sensitivity you can go is up to 10 to the power minus 5. But for both flow cytometry, especially the next generation flow and with the next gen sequencing, you can go up to even deeper level of sensitivity at 10 to the power minus 6. And turnaround time is very quick for flow, but about in days, up to 7 to 10 days for sequencing. And standardized wise, ASO PCR is relatively standardized. VDJ sequencing is very well standardized with one platform, the adaptive platform in the US, and the Euroflow is standardized for the next generation flow cytometry. So these are some of the pros and cons, and that needs to be taken into account when we decide what test to order or what assay to order and how to monitor these patients. Now, a brief word on how to monitor MRD by using next-gen sequencing or by adaptive platform. So this is because in the US, this is what most commonly used, and this is the one that is approved by the FDA probably 3 years ago. So what you're doing is you're looking at the VDJ sequence of this immunoglobulin receptor in B cells. So we all know the antigen recognition by both B and T cells is through the surface receptors. In the case of the B cell, it is the immunoglobulin located on the surface, and in the T cell, it's the TCR receptor. And in both the receptors, there is a VDR region, variable diversity and joining region, which is very unique to that. So when the B and T cells undergo maturation, these B and T cells also have this VDJ recombination happening at the same time to give a very unique sequence to that particular cell, whether it's a B cell or T cell. So in this case, it's a B cell. So these are some of the genes that is involved in the variable diversity and joining segments, and they go to different recombination pattern to give a very unique sequence particular to that cell. So what you're looking at in the next-gen sequence technology is looking at that VDJ sequence. And that is very unique to that particular cell, whether it is a mammalian cell, like plasma cell, or non-mammalian cell. And that is conserved across, very well conserved in the mammalian clone. So it is very specific to that particular cell. And when you have a very good sensitivity with that, then you are really kind of looking at that particular cell that you are of interest. Now, this is the pathway that follows through when you order the test with the MRD assay by next-gen sequencing. Of course, you need a baseline sample because you need to ID the sample, because that is the one that is followed through time. And once you collect the bone marrow, then that is sent to the adaptive lab, and where they do this PCR to look at this VDJ sequence, which is amplified, and with the help of next-gen sequencing, that is kind of looked at, and then the patient data is delivered within about 2 weeks of by a very clinical report, very easily, that can be interpreted very easily. Now, what is the value of MRD in myeloma, and what is the data so far shows? So this is the results of a French study, the IFM 2009 study. I'm sure you are aware of this study, which is a randomized study, a phase 3 randomized study that looked at early versus delayed transplant in multiple myeloma in the context of modern induction regimen. So in this, about 700 patients were randomized after initial induction with the VRD. They went into early transplant, one group, and then followed by 2 cycles of consolidation with the VRD and go on 1 year of maintenance. Whereas the other group opted for delayed transplant. So they went on 6 cycles of VRD, followed by REM maintenance for 1 year. And those patients who had a first relapse, then they were then mandated to get the stem cell transplant. So the first time in a prospective study, the MRD, especially by the NGS, was studied in this study. So this is the results of that MRD result. So if you look at the MRD level assessed by the next-gen sequencing at the level 10 to the power minus 6, if you just look at that, in patients who had just gone early transplant, means the patient who had a VRD induction followed by transplant, the MRD negativity rate at 10 to the power minus 6, so this is the most sensitive assay by the next-gen sequencing, is about 30%. But when you compare that to the delayed transplant group, the MRD negativity about 21%. So that tells you that using the stem cell transplant, you are able to achieve a deeper level of sensitivity and higher proportion of patients to achieve this MRD negativity. Now, when you look at on the left side here, there are 3 important observations. The first observation is the first graph here is for the MRD level before maintenance. So as I mentioned before, there is these patients went on to 1 year of maintenance treatment. So before maintenance, and they looked at the MRD by next-gen sequencing, and those patients very clearly saw those patients who are MRD negative before the maintenance at 10 to the power minus 5, they had significantly superior progression-free survival compared to patients who didn't have MRD negativity. Then they looked at the patients who had 1 year of maintenance, and then they also saw the same thing. The patients who are MRD negativity after 1 year of maintenance, their PFS is significantly superior as compared to the patients who are MRD positive. And when they looked at the overall patient population, the MRD positive patients had the median PFS of about 29 months, compared to the MRD negative patients who had MRD, where the PFS, median PFS was not reached, suggesting that MRD has a very good, has a very good prognostic value in predicting the PFS in these patients. Now, the more detailed observation on the right side here is to look at different subgroup analysis. For example, in the figure A, you looked at the type of treatment. So what it shows is very important observation. What it shows is that as long as you achieve the MRD negativity, whether you do by transplant or by just RVD alone, they do the same. So it really doesn't matter what type of treatment that you go, you do the same as long as you achieve MRD negativity. So if you see here, patients who are either they went to transplant or none, if they are MRD positive, they didn't do well. Then you looked at the cytogenetic risk. I think this is the most important observation of the study. When they looked at the patients with a different risk profile, especially with the standard and high risk, you look at, as long as you are MRD negative, it really doesn't matter whether you are high risk or standard risk at the time of diagnosis, you do pretty much the same. As compared to the patients who are standard risk and MRD positive, they are like intermediate, but the worst patients are the high risk and MRD positive. So if you are high risk, if you are MRD positive, that's the worst outcome. But at the same time, if you are high risk but are able to achieve the MRD negativity, then you do the same as standard risk patients who are MRD negative. I think this is a very important observation and will have a very wide implications in the practice. And lastly, same thing at the risk, the stage also is the same thing. It really doesn't matter what stage you are in at the time of diagnosis. If you are MRD negative, stage 3 patients do the same as the stage 1 as well. So suggesting that the risk could be dynamic in multiple myeloma, and that dynamic profile can be monitored by the use of MRD. But what the data tells us is that if you do the stem cell transplant early, the chances of you achieving the MRD negativity is higher because it's 30% versus 21%. Now, what are the other data? What is the role of MRD in high-risk patients? So we clearly saw that the high-risk patients, if they achieve MRD negativity, they do the same as standard risk patient. But in general, we know that a high-risk and standard risk patients, they're very sensitive to the treatment. If you look at the CR rate or even deep response rate, they are pretty much the same. But even with the patients who achieve CR, but the survival is differed by risk. People who achieve CR in high risk, they don't do the same as the standard risk patients who achieve CR. So what it tells you, the legitimacy of CR as an endpoint. So probably CR is a suboptimal endpoint, especially in patients with high risk disease. And is there any significance of, or the biology of the MRD clone that persists after treatment by risk status? So that is another conundrum that exists in this setting, especially if you saw that CR is not enough for these patients, especially for the high risk patients, and even they achieve the CR, they relapse earlier and they have worse outcome than the standard risk patients. So it is biologically driven at the MRD level, or at that deep level, it is driven biologically different, and that is another question that comes up after this observations. Now, so to answer that question, and the Spanish group very eloquently designed a study in their PETIMA-GEM trial, which is their the big study in the context of VRD induction. So the design of the study is shown here. So the patients, all newly diagnosed multiple myeloma, transplant eligible patients, they go on to VRD induction for 6 cycles, and they go on to either MEL 200 or BU-MEL. So it's a randomized MEL versus BU-MEL, and they go to consolidation with the VRD for 2 cycles. And here they are randomized to either a Revlimid Dex maintenance or ixazomib Revlimid Dex maintenance for 2 years. And after 2 years, they are again randomized by MRD. So if you are MRD positive, you continue with the Revlimid Dex maintenance. But if you are MRD negative, regardless of which arm you are, you stop Revlimid Dex. So we don't have the data on this one. So this is a very interesting trial looking at MRD as a decision-making tool here. Then the total maintenance the patient goes for 3 years. So here they try to investigate the questions of the biology behind the MRD, and then probably establish the role of MRD or the significance of MRD in different risk profile. So this is the MRD level at different cytogenetic risk. For example, here this is the standard risk people, and as you can see that and here it is shown where they did the MRD. But this MRD level is after consolidation, so that means after 2 cycles of VRD after transplant. As you can see, the undetectable MRD in the standard risk is 49%. So about 49% of the patients who did the standard model induction and transplant and consolidation, about half of them were able to achieve the MRD negativity at 10 to the power minus 5 level. So this is the Euroflow measurement of MRD assessment, which is which is what the Spanish group have developed. This has sensitivity up to 10 to the power minus 6, but for the regulatory purpose, 10 to the power minus 5 has been used in majority of the studies. So here at the level of 10 to the power minus 5, and here they have given the different level of sensitivity. As you can see, almost half of the patients were able to achieve the undetectable MRD. So pretty impressive. That shows the powerful activity of this treatment. But unfortunately, or as compared to that, only 1/3 of the patients in high-risk patients were able to achieve the MRD negativity in this high-risk group. Here you can see about almost 63% of the patients were MRD positive after. So in terms of the MRD achievement, even though they might have this similar standard response criteria, when you look at the MRD level, the response differs by risk group. So half of the patients versus 1/3 of the patients. So this is an important observation. Now, what about the impact of this achieving MRD in this patient population by risk group? So you can see here for both progression-free survival and the overall survival, if you achieve MRD negative, so there are different groups: standard risk MRD negative, standard risk, high risk MRD negative. So if you are MRD negative, same observation that we saw in the French study, if you are MRD negative, it really doesn't matter whether it's standard risk or high risk, you do the same for progression-free survival. And the worst players are the one, same as before, high risk MRD positive. So if you are high risk, having MRD positive portends a very bad outcome compared to the patient who are standard risk MRD positive. And similarly for the overall survival, the similar observation as we saw in the French study, if you're MRD negative, regardless of the independent of your risk status at the time of diagnosis, you do pretty well, or relatively much better than other subgroups. Now, this is the one they looked at patients with del17P, which we know is the highest, one of the highest risk group. And as you can see very clearly, this is the patient, each patient that is followed over time, and the gray is the mean time to follow up, and the purple is death, and the orange is the time of progression. As you can see, for undetectable MRD group, this is this number of patients, there is just one progression event and no deaths. So that suggests that having an undetectable MRD in high risk is definitely an important endpoint. Whereas in the patient who are persistent MRD, in high risk patients, you can see a lot of progression, including deaths as well, and validating what we saw here in one small subgroup of the high risk patients. Now, so those two observations have been pretty kind of settled by these two studies, two large scale studies. And also we have seen in other smaller studies that the high risk definitely can be overcome, or the negative outcome of high risk can be overcome by MRD as a tool or as a dynamic tool. Now, what drives those MRD clone in different risk group is the second level of question that is being investigated. And that question is answered in the same study that as I showed you. This is again the same the Spanish study that looked at this VRD induction transplant and VRD consolidation. And what they did was, with the different next generation technologies, in particular, when they looked at the MRD clone for both standard and high risk patients, they kind of sorted those clone out by fluorescent activated cell sorting. And with the use of next-gen whole genome sequencing, bulk RNA, and single RNA sequencing, they were able to look at gene expression profile of this MRD clone and compare that with the diagnostic clone. So what they found out is, when you look at the gene expression profile, the paired gene expression profile for the diagnostic and MRD clone, there is greater clonal selection of MRD cells in the standard risk group. But more importantly, there are some unique pathways that is upregulated in the high risk. As you can see, the ROS pathway, the antioxidative gene circuitaries, are highly expressed in high risk MRD clone, suggesting that the biology that mediates the MRD clone is different in standard risk and high risk. And that probably calls for some new or novel agents to clear the MRD in two different subgroups as well. So of course, this is a very important observation that should be explored and that should be kind of studied in other studies to see what is the biological conundrum that exists in these different risk profile groups, because this could provide a very important dynamic tool to overcome some of the bad outcomes that that can happen, that is present in patients with the high risk myeloma. Now, what assay is better? Is NGS better, or next-gen flow or flow cytometry assays better? So that question is now being answered in several studies. So this is the first study that tried to answer that question. This is an investigator-initiated trial with a group from Madan Sloan Kettering. They used this in about 45 patient study. They included 12 patients with the small ring myeloma and about 40-something patients with the 35+ patients with the multiple myeloma, where the patients got KRD induction followed by R maintenance, so they didn't go to transplant, but they had the MRD as one of the endpoint, and by both assay, both by next-gen sequencing and by MFC, at the 10 to the power -5 level, and even up to the 10 to the power -6 level. So as you can see here, this is a very small study. The overall PFS is given here in 45 patients, but these patients are MRD negative by a multicolor flow cytometry, and you can see even if you achieve the MRD negativity, there are some relapse event happens in out of 33 patients. But here, in all the patients who are MRD negative by NGS, none of them relapsed at the time of the last observation. And then patients who are PET positive or PET negative, there was no difference at all. So what suggests that maybe NGS MRD is probably maybe a better technology or better assay to predict the response or predict the outcome. But this question was then answered in two major trials. One is a Cassiopeia trial, which is the French study that looked at the use of DARA in the upfront setting in the transplant eligible multiple myeloma patients, where patients get DARA VTD or VTD, and then go on to transplant, and then go on to consolidation of 2 cycles of DARA VTD or VTD. So that question they answered by doing both NGS and multicolor flow cytometry assay and compared that to each other. They found a very good concordance rate in that. And similarly, the other study called Forte study that which looked at the KRD induction followed by transplant versus KRD consolidation. And the other arm is KCD induction followed by transplant. They also looked at that by MRD, looking at the MRD by different ways, by next-gen sequencing versus flow cytometry, and they found there is a high concordance rate as well. So at this point of time, I think if you are at the similar level of sensitivity, whether you're 10 to the power -4, 10 to the power -6, if you're at the same level of sensitivity, both multicolor flow cytometry and next-gen sequencing are equally good in predicting the response, unless the few other large studies kind of show otherwise. Now, we talked about the data that we talked about is looking at the role of MRD in newly diagnosed multiple myeloma patients, in particular patients with that who underwent transplant. So what about the patients? There are a significant number of patients relapse in myeloma. We all know that. And what about the role of MRD in relapsed refractory multiple myeloma and the patients who are transplant ineligible? Because about a majority of the patients don't get to refer to transplant. So there are a lot of patients by that, or not, some of the patients don't get ineligible, are not eligible for the transplant. What is the role of MRD in those patient population? So there are, in transplant ineligible, that question was assessed in the first time assessed in this trial called Alcyon trial. So Alcyon trial is mainly the European trial where they looked at the use of daratumumab upfront in the transplant ineligible patient. The VMP, Velcade, melphalan, prednisone, was a standard of care at that point of time. So they added daratumumab on that. And daratumumab, Velcade, melphalan, prednisone is one arm compared to VMP, the control arm. And they showed the Dara VMP was associated with significantly improvement in progression-free survival and in the long-term follow-up and overall survival as well. And that led to the approval of the Dara VMP as a regimen of choice as a frontline regimen for transplant ineligible patient population. And in that study, they looked at the MRD assessment as well by next-gen sequencing at 10 to the power -5 level. And what they showed as the people who received Dara VMP, about 22% achieved MRD negativity, significantly higher than the patients who just received MRD, in the VMP group. But what it showed is the same thing that we have been seeing before as well. As long as you are MRD negative, whether you achieve by Dara VMP or VMP, it really doesn't matter. So MRD negativity, achieving that is significantly associated with the superior progression-free survival, as shown here in that graph. It really doesn't matter. It's just that there are VMP people, higher number of patients got MRD negativity. But as long as you achieve that, it doesn't matter. And again, establishing the the prognostic role of MRD negativity. Now, what about in the relapsed refractory myeloma patient? So as you know, the patients who are relapsed refractory, they have different choices, and one of the choices is Dara-Velcade-Dex, and that was established in a study called Castro study, where they randomized patients Dara-Velcade-Dex versus Velcade-Dex, which was then a standard of care for those patients. And as you can see, they looked at the MRD at different level of sensitivity. Dara, of course, using Dara increased the level of sensitivity, but that showed that achieving this, and that is associated with significant benefit as well. So they established the role of the MRD negativity in relapsed refractory myeloma patient as well. And similarly, the other companion study called Pollux study, which looked at the combination of daratumumab with Revlimid and dexamethasone, also looked at in patients with 1 to 3 prior lines of treatment. They looked at the role of MRD negativity or the MRD assessment at different level of sensitivity up to 10 to the power minus 6, as shown here, using the daratumumab significantly increased the rates of MRD negativity at all level of sensitivity, and also translated into superior survival benefit, especially the progression-free survival benefit. Now, recently, the study, the one study came out that looked at the pooled analysis of the value of the prognostic value of MRD in both relapsed refractory multiple myeloma and the transplant ineligible newly diagnosed multiple myeloma. So what this investigator did was they pulled the analysis from Alcyon, which is the study that I just mentioned, Castro and Pollux, which is the one that I mentioned, and there is another study which looked at the use of daratumumab in combination with lenalidomide and dexamethasone, called Maya study, and compared that to lenalidomide and dexamethasone, and which showed the superiority of the DRD in transplant ineligible patient population, and that also led to the approval of DRD, and that is the one used in the US most frequently than Dara-VMP. So this investigator pulled the analysis of and looked at the value of MRD in these two different subgroups of the patients. So here on the first, on the right hand, on the left hand side of the curve, what they looked at all the patients who achieved MRD negativity. So this is the pool analysis of relapsed refractory and transplant ineligible patients. So what they showed is that the MRD assay was done by next-gen sequencing at 10 to the power minus 5 level of sensitivity. And what they showed is that if you are achieved CR, more than CR, MRD negative, then your outcome in terms of the progression-free survival is significantly higher in patients who are either MRD positive or less than CR. So that shows the value of achieving MRD negativity in CR patients. And they looked at some subgroups, for example, the patients who are relapsed refractory and had just 2 prior lines of treatment. And when they looked at and combined with the transplant ineligible patients from both Alcyon and Maya study, they found the same thing. Patients who are MRD negativity and CR, their outcome is significantly higher compared to patients either they are less than CR or they are MRD positive, regardless of the depth of response. This is one very important observation. Now, the other thing that they looked at is looking at the CR patients. So I think that tells you the legitimacy of the CR, or tells you that the CR is not enough. When they looked at the patients who are just CR, if you are CR, that is not enough. You need to have MRD negativity to have the best outcome, as shown here. So for example, at the 48-month PFS, you can see that the PFS was about 71% of the patients who are MRD negativity and CR. But even if you achieve CR, but if you are MRD positive, you can see there is significantly inferior PFS benefit in those who are MRD positive. So that kind of underscores the value of MRD negativity in CR patients. And this is by treatment subgroups. Obviously, the patients who with Dara, they have higher CR and higher MRD negativity, and they did the best. But the patients who are non-Dara control group, as long as if you are CR and MRD negative, they know that they also did significantly better than the patients who are MRD positive. So as long as you get to MRD negativity, it really really doesn't matter, but you just need to look at the options that give you the higher chances of getting into MRD negativity. Now, so is the MRD the only thing that matters? The standard response criteria, does that matter? So that all this, the observations of the study that we discussed, that raises one important point. So achieving CR is not enough as long as you are MRD negative, MRD positive. And so what that means is what the all the other standard response criteria that we looked in these patients. For example, partial response, very good partial response. We even have stringent complete response and all those stuff. That really matters in myeloma. So do we have any study that looked into that? So again, the same question. The Spanish group that study we looked at, the PTMI study, tried to investigate that question. And this was recently published in Blood. And what they looked at is they looked at the standard response criteria at different time points. So as if you recall, these patients went into VRD, 6 cycles of induction, then they had MRD assessment done, they went to transplant, and then they had MRD assessment done at another second time point, and then they had 2 cycles of VRD consolidation and had MRD assessment done. But at the same time, they also had standard response criteria at those time points. So when they looked at these patients, so these are the patients and after induction. So if you see after induction, it really does matter if you have standard response criteria, CR and SCR. Those patients who have CR and SCR, they definitely did much better than patients who have less than that. Similarly, after transplant, it did matter. If you are CR and SCR after transplant, you do better than the patients who don't have that. But after consolidation, after 2 cycles of VRD, it really didn't matter. It really didn't matter. They all did the same. Very surprising result. Okay. Now they went to look at the MRD on this patient. So this is what I think the answer is here. So if you look at those patients, this is after consolidation, and look at the MRD. So if you are MRD negative, and they try to compare that with the patients who have different standard response criteria. So if you look at that, it really doesn't matter. There is 2 distinct groups, very clearly shown. All the standard response criteria group in one who are MRD positive, but regardless of that, if you are MRD negative, you do better. Very interesting observation that calls for the value of the other standard response criteria in myeloma. Now, what about the value? What about the role in progression and overall survival? That one was the progression-free survival. This is one for overall survival. Same observation. Very interesting, same observation. So regardless of your standard response criteria, whether you are CR, SCR, VGPR, all these subgroups, it really doesn't matter as long as you are MRD negative. So that means the prognostic value of MRD negativity supersedes the standard response criteria in both progression-free survival and overall survival that calls for potential modification of this standard response criteria in multiple myeloma, and to see what is the best way to monitor this disease. Of course, this is a one group study, which is about 400 up to 500 patient study. This needs to be investigated in other large group setting, and to see if MRD, if that holds true in that case, then we might, that might calls for revisiting the response criteria in multiple myeloma, and again establish the prognostic value of MRD as a tool. Now, when you talk about MRD, the one thing that you always have to think of in myeloma, just in the inherent nature of the disease, is the clonal and spatial heterogeneity. This is very important because, as we all know, when you do MRD, at one space, at one point, when you look at the marrow, you are just looking at one very small area of the disease, and myeloma is a very patchy disease. So you may or may not be able to get the full picture or the global picture of multiple myeloma when you assess that disease. So this is one of the shortcomings that we have with the current MRD assessment tool. So this is on the left-hand side. This is the genomic analysis, or with the hybridization techniques. They looked at the different clones at the time in a patient, like kind of a whole life, the myeloma journey. So this is at the time of diagnosis. As you can see, the copy numbers and the clonal dominance at one particular clone is 72%. And as you can see, the patient got treatment with Lendex at induction. They go into remission. The clone went down to say 64%. Then they had a first relapse. In the first relapse, as you can see, the clone is completely different clone. So there is a different alternating dominance of the clone, which is very classical in multiple myeloma. Then you go on different treatments. As you can see, the clones dominant over time and alternate over time. Ultimately, the patients become very refractory and then becomes plasma cell leukemia. So this is very unique to that particular patient, but it's very common in patients who go to multiple relapses. The alternating dominance clones and sweeping clones over time is very common in myeloma. But what about the spatial heterogeneity? So that study, that question was asked in this study on the right-hand side. This is a study by Leo Rossi. When he was in Arkansas, he looked at about 51 patients who had kind of myeloma with the bony disease, and then they're doing a bone marrow biopsy at different time points or different areas, for example, iliac crest biopsy, and then one focal lesion. Then he looked at the genomic profile of these patients. And what he found out is that there is a spectral heterogeneity in more than 70% of the patients. So that means just looking at disease at one time at one area is not enough. So what that suggests, or what it tells you, the mechanism of evolution of disease. So that could be the early sweeping of the clones at one time when the disease starts. But once the disease goes in different areas, and there is already a regional evolution that happens, and that gives a different disease in that area or different morphology, at least in genomically, there is a different disease at that area, and that could impact the disease monitoring, and that could also impact how we predict the response in those patients. So it's an important thing to consider that in myeloma. Now, to answer that question, is partly done by the French group in looking at the role of imaging myeloma in the context of MRD status. So this is again the French study that I mentioned before, BRD induction followed by early versus delayed transplant. So about 155 patients were enrolled in the study, and what they did was they randomized these patients into two groups, arm A and arm B. Everybody got PET CT or MRI, and then at diagnosis, they are randomized into PET arm or MRI arm, and then here they, after 3 cycles of RVD, they went into again got PET MRI before maintenance. So of course, the study showed that the MRI and PET were both equally sensitive in detecting these lesions at the time of diagnosis, but PET was better in terms of assessing the response or the functional status in predicting the outcome. But what they showed is interesting. These patients who are before maintenance, they had both are MRD negative by multicolor flow cytometry and PET negative, they did the best. So double negative is better. So that means if you are MRD negative by one assay or at one point of time at one area, is not enough if you have a PET positive disease. So it's important to look at the imaging and to assess the MRD negativity for those when they are MRD negative as well. So this study brings up hopefully the further new studies or the further studies will try to answer the question, the role of imaging in the context of the MRD. But at this point of time, it is complementary to have the PET imaging status in conjunction with the MRD status in kind of having a better prognostic answer to the patient. So keeping that thing into mind, in 2016, International Myeloma Working Group added the MRD as one of the endpoint in the response criteria. So as you can see, this is just a snapshot of that. The standard response criteria, we all know what is complete response, stringent complete response, very good partial response, and all those. But they added the IMWG MRD criteria, which means you need to have, so one difference here we have to note is the patient needs to have a complete response before we assess the MRD negative, MRD status in these patients. As you know, in the clinical trial, in the day-to-day practice, we might just do the MRD in all the patients. But for IMWG response, you need to have a CR first before you look at the MRD. And there are different ways that you can look MRD, some of the ways that we just discussed, flow-based MRD by next generation flow or Euroflow, sequencing-based MRD by the one that we described just now, and the imaging plus MRD. So keeping into mind the imaging is equally important. So they have imaging plus MRD, and they also try to define the sustained MRD negativity. And this is still the open-ended question right now, but what they define is that sustained MRD negativity is MRD negativity by either NGF or NGS, or both, and by imaging at the minimum of 1 year apart duration. So this is what this is being defined, at least in the current setting for the IMWG criteria. Now, what are the challenges with MRD? There are a lot of challenges. Of course, you already saw that. There are a lot of unanswered questions. But what is the main challenge that I see as a clinician is this not to able to assess the global disease burden or the global status of the disease. Of course, the assay depends on the quality of the samples. So for example, marrow is a patchy, and you may not be able to assess the whole myeloma status with the one-time bone marrow. That is one problem. The other problem is depends on when you pull the sample. For example, if in our day-to-day practice, when you do a bone marrow, you get the first pull go to pathologist for morphology and cytogenetics. Usually the MRD is assessed after like 3-4 pulls, and especially if they are done in the research setting, they are assessed after like 3-4 pulls. But in general, that could dilute the samples, and that will impact the assessment of MRD. The other one problem is myeloma. As we have developed the new treatments and new kind of therapeutic armamentarium for these patients, we're also seeing a lot of secondary extramedullary disease. And for those patients, MRD assessment might be giving to false negative results because they cannot capture that. The third is, if MRD is a very powerful tool, which it's a powerful tool in predicting the response, and if it becomes a clinical endpoint for day-to-day practice, to use that for patients and to frequently monitor the disease by using invasive nature of the bone marrow for these patients is definitely a limitation. It's always, because we are doing a lot of trials right now where patients need to go through bone marrow with multiple bone marrow biopsies, and it's already a lot of cumbersome, a lot of discomfort for those patients. So that is another challenge. And lastly, that the same thing that we talked about, the spatial heterogeneity and the regional evolution of disease, just doing 1 point bone marrow is not gonna able to capture that. So that challenge we have. So this is, I think, if you ask me, this is some of the most kind of important challenges in MRD assessment. So to overcome those problems, there is interest and there is effort to look at that by doing a blood-based MRD, and with the idea that if you look at the blood, you should be able to capture that all those heterogeneity we talked about, and it's going to be less invasive, and you can frequently monitor the disease with equal sensitivity, and also could predict the outcomes as equally as the MRD in these patients. So the blood-based MRD is definitely one of the solutions that we could think of. Now, what are the data so far in using the blood-based MRD? So if you look at the ways that you can look at the blood-based MRD, there are mainly three ways. One is you can look at the circulating plasma cells. The other way you can look at the cell-free DNA, and there is another one is mass spectrometry, basically looking at the immunoglobulin gene, immunoglobulin protein in terms of molecular mass. So mass spectrometry is one. There are three different technologies coming up. So this is a study by a French group that looked at the blood-based MRD using the next-gen sequencing. What they did was they did the bone marrow biopsy and did the MRD by next-gen sequencing, and with the similar technology, they tried to do the peripheral blood MRD assay. But what they showed this is about 37 patient study, so very small study, but there is no connection between that. So there is definitely disconnect. There is a lot of discordance in that, suggesting that the blood-based MRD by this technology is not the same as the bone marrow-based MRD. So that means the patient who are still negative by blood-based MRD or still positive by the bone marrow-based biopsy. So they're not kind of equally in the same page. Now, the other technology that what we have been interested, we have a little bit of interest, and we are trying to explore that is looking at the clonal variants of the disease over time. So this is with the technology, how we do is we sequence a tumor at the time of diagnosis to get this the genomic makeup of those tumor cells. And then first we collect the bone marrow biopsy, and then with the help of deep sequencing method, we first create a library and of 16 different clonal variants that is very unique to that patient. And once that is done, then we obtain the whole blood sample of the patient at the time of diagnosis, and then we try to look at that library of that in the peripheral blood and monitor this disease by circulating tumor DNA over time. And this is the technology that is being used in other cancers, in solid cancers like lung cancer and colon cancer. So with the similar technology that we investigated whether that can be used in multiple myeloma, and where circulating tumor DNA can be used to monitor the disease and predict the responses. So this is the study that we did in the archived sample of the patients that we had. We had about 700 patients who went to study and had samples stored from 2007 to 2012. And we kind of looked at those archived sample, and out of 50, we had 52 patients who had archived sample, including the FFP, bone marrow, and then the plasma sample at different time points. And out of that, 20 patients made the quality test, and of those 20 patients, there were 80 plasma samples that passed the quality test, and we're able to design the assay. It's called Signatera assay. This is the assay that is being used is already FDA approved for the lung and colon cancer. So you design this assay for 28 patients, and these are the assays that were available. 24 patients at the pre-transplant time point, 28 patients at 3 months post-transplant, and 28 patients 1 year. So and looked at that assay using the peripheral blood or the plasma at 3 different time points: pre-transplant, 3 months after transplant, and 1 year after transplant. What did we see? So this is the different patient profile. So here the dark circle is the patient ctDNA positive, the white is ctDNA negative, and this is the progression, and this is the death. As you can see, it is a very small study. It didn't really kind of give a clear picture of this prognostic ability of these patients with the different time points ctDNA. But as you know, the post-transplant or the post-treatment MRD is the most prognostic outcome. You saw that in the Spanish study. Patients who are CR, SCR before after induction or after transplant didn't really matter. After consolidation is really matter. So post-definitive treatment MRD status, since that was the most prognostic for the outcome, we look at the 3 months ctDNA status and we looked at the prognostic ability. So interestingly, of those patients who are ctDNA negative at 3 months post-transplant, their PFS was significantly better as compared to the patients who are 3 months positive with the ctDNA. Then in those patients, we have the institutional MRD assessment done for all those patients after transplant by doing the next generation, by using the flow cytometry at the sensitivity of 10 to the power -4. And as you can see at that point, when you do the flow cytometry status, it really didn't matter whether MRD positive or MRD negative by flow. That really didn't predict the outcome. And so it is a very interesting observation here. And then here is another observation, is that patients who are MRD negative by Signatera assay, their relapse rate was significantly lower than the patients who are flow negative by the flow assay. And so that means the positive predictive value is much higher in those 28 patients by using the ctDNA. And we try to look at the impact of the ctDNA in adjusted analysis, and we adjusted that for age, the cytogenetic risk, and the flow. And as you can see, having negative ctDNA at 3 months after transplant, their PFS, or they have significantly impact on the survival. This is the progression-free survival as compared to the age. And the fish, we know the fish has significant effect on the outcome and the flow, but none of them really did matter. The only thing that was significant was ctDNA. So this is a very interesting observation, of the very provocative observation at this stage. Of course, this is a very small study, and we cannot derive any definite conclusions at this point of time. But what it tells you, the two important observations. One is you can use the archived sample in more than half of the patients and can assess the disease using to use ctDNA in these patients. And number two, the early results are very provocative and very interesting, and it needs to be validated in a large scale setting. So at this point of time, we are doing a next step, which is, of course, the validating that in large sample, which hopefully will complete soon. And the number two is doing it prospectively and comparing or cross-validating with the available assay. And our goal is to cross-validate with the MRD-based assay to see if ctDNA can give equally the same answer or maybe better answer in predicting the outcome of these patients. In that case, you don't need to go for the invasive bone marrow for every time when you monitor this disease. So then I'll go into the next case, and we can discuss that during the discussion. This is a patient, very common question that I always get right now because the MRD is everywhere, and patients know about it and they want to ask this question. So this is a 53-year-old African American female, again a patient of mine, who was diagnosed with kappa light chain myeloma, RISS1 with 1114 translocation, diagnosed in October of 2012. She was treated with 4 cycles of VRD and then underwent tandem transplant on this trial. So she went 2 transplants back-to-back, auto transplant. Following this, she was started maintenance 10 milligram daily, subsequently reached to 5 milligram because of cytopenia. She has remained in the near complete remission since transplant. So, in general, she has been in complete remission since transplant for almost 7 years. The study closed in 2018, and no longer will be supplying Revlimid for her because she was getting Revlimid from the study, and then now she has to use the commercial insurance. So she wants to stop Revlimid maintenance for her. So what do you do in these patients? Continue Revlimid through her private insurance, stop Revlimid and watch her number at least 3 months, stop Revlimid, perform NGS by MRD and resume if positive, stop Revlimid, perform MRD by NGS and permanently discontinue if negative. So these are some of the very very unique kind of clinical questions that you are encountering now, because now we have MRD assay and we have patients on doing very well in Revlimid maintenance or doing very well in therapy. And so one of the common questions that patients ask us is, can we stop the treatment or can we de-escalate the treatment? And now the question is, can you use MRD as a tool to guide that? And we'll discuss that in the discussion. Now, so what are the more challenges that we have with MRD is we talked about the threshold. The threshold defined by IMWG and for regulatory purposes 10 to the power minus 4. But we know that deeper sensitivity matters, like 10 to the power minus 6, you are able to detect even more cells in that. So this, which one is the good optimal threshold? We don't know that. NGS or NGF, I think we have the answer, because we know that as long as at the same sensitivity, they are pretty much the same. It all depends on how comfortable you are, or your institution is, and what kind of expertise you have available there. And that is there. For in the US, we do NGS because that is one that is approved by the FDA. Then the time interval to define sustained MRD negativity, we don't have answer for that, and this is being investigated in the clinical trial. As you said, as I said, the IMWG said 1 year as a sustained MRD negativity, but is that enough? We don't know. Timing of MRD assessment. This is, I think, a very important question because we saw that we can do MRD after induction after every treatment, but we don't know what is the time point that we really think that is the most prognostic of the outcome. And meaning of MRD in particular subgroups. I mean, we know partly that answer. For example, the MRD in high risk is different than MRD in standard risk. But what if the MRD in other subgroups and even in the high risk, what is the role of MRD at what level of MRD is important. And we don't have standardization of MRD by PET CT. I mean, there is some studies going on, but we still don't have the standardization. And we have not been able to use MRD as a surrogate endpoint for regulatory purpose at this point of time. So these are some of the challenges that we are encountering with MRD. Now, what could be the future role of MRD testing? What I can think of is we can think of MRD as a surrogate endpoint for drug approval. The way the data is evolving and the way the trials are evaluating the role of MRD, it's quite possible that that could be used as a surrogate endpoint for drug approval. Of course, MRD is a prognostic tool, and we know that, but whether that is used in the clinical practice, it is not that commonly used, but it will be used most likely as a prognostic tool. And use of MRD as an actionable thing means like a use for treatment decision making, escalate the treatment, de-escalate the treatment to define the success of certain treatment, and then to define a timing of intervention. For example, whether you want to add the therapy and what kind of intervention is good for those patients if you are MRD positive and what level. Those are the things I think that we will be investigating in the future. Now, what are some of the potential kind of a hypothetical study design that you can think using MRD as an endpoint? For example, patients with subjects with relapsed refractory multiple myeloma, they go on to use a novel agent first plus standard of care, and then they continue the standard of care. Then your primary endpoint is MRD difference, and you decide what is the difference that you want to achieve based on some null hypothesis, and then you go to accelerated approval of this drug, because that means you can get the drug approved and given to the patient quickly, and then you have regular approval after the follow-up for the PFS or OS data. That is one hypothetical study design that you can think of. And for disease like myeloma, you could think of using MRD as an intervention tool at different time points or different stages of the disease. For example, this is after induction, do the MRD testing. If you're MRD positive, you do additional induction. If you're MRD negative, you can randomize into early versus late transplant and so on and so forth. Similarly, after transplant, you can do MRD testing. So there are a lot of hypothetical situations where you could use MRD, but to be honest with you, there are a lot of trials that are already evaluating or in the process of evaluating in this setting, in this kind of situation, using MRD as a tool. And then you do MRD. If you're positive, you go on consolidation or no consolidation. If you're MRD negative, then you just go on maintenance. Similarly, you can do after maintenance to decide whether the patients can go on maintenance or can stop the maintenance or can give just limited duration of maintenance. And lastly, for the transplant ineligible patient like that, you continuously give the treatment, and at certain time point, you just look at the MRD, and based on that, you can, for example, the patient like mine, that the second patient of like mine, where you are on MRD, the Revlimid maintenance for about 8 years, and you want to stop the therapy or you want to de-escalate the therapy, and that's kind of situation that we can design the study like that. So this is some of the kind of concepts that we can think of using MRD as a tool, and several of them are already being explored in the clinical trials. Now, we did one trial called Master Trial, where we used MRD as one of the decision-making tool in stopping the therapy. So this is the design of the trial. We completed this study, where part of this was presented at ASH in 2019, and we're presenting the data in this year ASH, the full data. So the patient go on to, they are all transplant eligible patients. They go on to DARA KRD induction for 4 cycles. So using DARA upfront with the KRD, and then you look at the MRD after that. And if they are second MRD, then you can, after the transplant, then they, if they are 2 subsequent MRD, they can go on to observation. If not, they go on to additional cycles of the consolidation, again with the DARA KRD for 4 cycles, and then if you are negative MRD at 2 time points, they go into observation. But if you are MRD positive, you go into consolidation for 3rd cycle of consolidation with the DARA KRD again, so total of 8 cycles of consolidation, and then anytime they go to 2 consecutive MRD, they go into observation. Otherwise, they go on to clear the MRD. So bottom line is using MRD as a tool to kind of to make a decision whether to observe the patient or give additional cycles of consolidation. So we finished this study. So this is the study that was presented, about 83 patient study at that point of time, was presented at ASH. We have 123 patients enrolled already, and we have a paper ready, actually submitted, and we have an ASH abstract submitted as well. So we'll see the full data at the time, but this is the data that I can tell you about what we saw in 2019 ASH. So this is very interesting. Using the DARA KRD, this is the different MRD time points, and this is the different level of sensitivity. As you can see, higher level of sensitivity, and as you give more therapy, you can see the deepening of the response. For example, 27% went up to 63% after MRD-directed consolidation, and only 47% after transplant. So the overall, the MRD rates were significantly higher, but we also saw that more people will achieve MRD negativity at each type of therapy. And we can see that we can track this MRD about 96%. So this is the data on 81%. So we have data on 123 patients now. And it's pretty holds the same true that you can track this MRD in these patients. And this is by risk group. As you can see, the similar thing what we saw in the Spanish group and in the French group. This is at 10 to the power minus 4, and this is at 10 to the power minus 6. As you can see, different level of MRD negativity. At 10 to the power minus 5, we have 82% achieve MRD negativity in all patients, with 63%. And here is standard risk and high risk. It's pretty comparable, actually. It's pretty comparable in these 81 patients. And then at 10 to the power minus 6, a little bit different. So 73% achieve MRD negativity at 10 to the power minus 6 after consolidation versus 42% in high risk patients. But regardless, this is pretty impressive response rate. And this is some of the study that looked at MRD, the recent studies that looked at the MRD as one of the secondary endpoints. And as you can see, as you have newer therapies and more modern therapies, you are able to achieve higher level of MRD negativity, whether it's NGS or by next-gen flow. For example, in the context of our US practice, you can see the French study, the IFM study we talked about, the MRD negativity was 30% with the transplant and RVD induction. And compared to that, our master trial, where you use DARA KRD transplant, DARA KRD consolidation, the NGS MRD at 10 to the power minus 6 was 63%, almost 100% higher. So this is very impressive. That tells you the value of these new modern therapies. And similarly, that in the DARA VTD group, much higher than the VRD group, suggesting that this newer therapies and quad therapies can achieve higher rates of MRD negativity. And now it remains to be seen whether that higher level of MRD negativity can translate into superior survival benefits as well. So in conclusion, deep sustainable remissions is a potential path to potential cure in multiple myeloma. You need to have that, to define a cure in myeloma. We saw that MRD negativity state or higher rates of MRD negativity state is possible due to availability of high efficacious drugs and the combination. VRD, we saw that rates of MRD negativity and deep responses, adding data on that even increase the rates to even higher level. Data clearly support the prognostic value of MRD. I think that is very well settled in myeloma. This is a very good surrogate for PFS and OS. We have shown that in several studies, including the large meta-analysis. Now, there are still several open issues in using MRD. We talked about that, some of them, including the potential value of the peripheral blood assay, best assay for MRD. And the good thing is that there are a lot of clinical trials, including the trial that we talked about, the master trial, that are trying to address these questions, whether the MRD can be used, A, as a prognostic tool, and B, as an actionable thing to use that in a treatment decision making. And it's most likely the way the field is evolving, MRD is likely going to be a future driver of the modern tailored treatment in multiple myeloma. I think that's all I have. And thank you, everybody, for the... I stopped.
Thank you, Dr. Binod. We're looking forward to this talk, and I must say they are more than happy with the thought-provoking talk that you gave, various gray areas which some have been sorted out and which remain gray to be further researched, and how this can be used in practice at the moment, and the futuristic views, how it can probably impact the treatment in future. Very, very thought-provoking. Thank you so much for bringing all these aspects of MRD in myeloma in front of us. So we have got, thank you. So we have a lot of delegates, and I request them to keep putting their questions in the question box, and we have faculty here. Many of them are very young, dynamic hematologists and oncologists, and they will be asking you some of their difficulties. May I begin with Dr. Abdul Shahid?
Hello, am I audible?
Yes.
Yes. First of all, let me thank Dr. Binod for this wonderful talk and enlightening all of us about MRD and myeloma. I think it's going to change how we practice in the next few years. I believe it is still not a standard practice, at least in India. So in India, we are actually now streamlining towards like how to treat myeloma as per the risk stratification. So now you have come up with a point that there is no point of any risk. What is important is somehow to get MRD in myeloma. So may I ask you, like, what is the best regime? Like, what do you think in a country like India, at least? What is the best regime that can give us the best possibility of attaining MRD? Dara is not very easily available. I think most of our population cannot afford Dara.
Yeah. So yeah, I think that's very important question. Even in the context of the US, I think that is important. The question that you asked. So as I showed you in the perspective slide, if you see if you add more regimen, in particular triplet compared to quadruplet, you see the higher rates of MRD negativity. But what the common denominator that we saw is the transplant. The use of transplant definitely increased the depth of response and also increased the MRD negativity rate. So if you look at the two important study in this context, one is the French study, which looked at early versus delayed transplant that I showed you, 30% versus 20%. So there is definitely higher rates of MRD negativity just by doing a transplant, even if you get the same induction regimen, number one. Number two, there is another study called Forte study. That is another Italian group study that looked at KRD transplant, and then KRD 12 cycles, and then KCD transplant KCD. Very interesting observation. Number one, if you do KRD, which is a very modern regimen, compared to KCD, KRD transplant, KRD consolidation, they achieve the same level of response and MRD negativity. So depth of response is good. But what it showed further is that if you do transplant, the rates of sustaining that MRD negativity or 1 year sustained MRD negativity, which is what I think is even the bigger goal that we want to have, just rather than having 1 point MRD negativity, the transplant gives them higher chance. About 95% of the patients were able to sustain that MRD negativity in transplant group versus the KRD consolidation or KRD just 12 cycles group only. So that tells you the value of transplant is still equally important, is very important, even in the context of modern therapy. So if you ask me, in country like myeloma, I mean, the India, where people can't afford the very expensive drugs, like Dara is out of the question, and then Revlimid could be very expensive. I'm not sure the exact pricing there, at least here is very expensive, but you can do triplet induction followed by transplant. That give one of the best possible situation for these patients to get into the transplant. I mean, triplet, when I say triplet, is triplet with the PI and IMiD-based combination triplet, whether it's thalidomide, and because we saw that in the DARA VTD and VTD group as well, the rates of MRD negativity can be higher if you do a transplant for those who are eligible. So at this point of time, I think I would still say the transplant is one of the very effective treatment to help them achieve the deeper responses and maintain that response.
Yeah. Thank you. And does your choice of maintenance, And the duration of maintenance, does it really affect on the, does it depend upon the MRD status? Like we have Carfil, you can give Borti, you can give Carfil, you
Yeah.
can give Len as maintenance. Like how does it?
The answer to your question is no, that really doesn't depend on the MRD status, but that is being investigated in the clinical trials. So that, remember the second patient that I have. So these are the very common questions that we are seeing now, because the patients are using this regimen for a long time. They are in a good response and they want to stop the therapy. That is one group. The other group is they are on maintenance and they're still having this low level of protein or slowly growing protein. Can you do additional thing on those patients? So these are the trial level questions which are being investigated. We don't have that data yet to act on that. Right now, the maintenance is mainly decided based on the risk status rather than the MRD. For example, somebody is a high risk, you try to do more than lenalidomide. If somebody is standard risk, then you just continue the lenalidomide. But the trial, there are a lot of trials. For example, we have a trial called S1803, the SWOG trial, which try to answer two important questions in myeloma. One is, can we improve upon len maintenance? So we know that there are a certain group of patients who don't, derive same benefit equally as with len maintenance. So can you do better with the len maintenance? So this study is randomize the patients to dara-len versus len. Okay. The next question is the question that you talked to raised. How long we have to put that maintenance for? Okay. So for example, in the French study, the people give for 1 year. But the original study that looked at the maintenance trial, like the CLGB study and the IFM study, that looked at the indefinite maintenance. So there is no clear answer on how long these patients need to be maintained on this drug as long as they're doing good. So there, how long the duration of maintenance question is being asked as answered or trying to be investigated at least by using MRD as a tool. So some of the hypothetical situations that I described to you, looking at MRD, and then try to see stop the therapy versus continue the therapy in MRD positive patients. So those questions are still being investigated. So we don't have that answer for now.
Yeah. Thank you.
Thank you. Taking from Dr. Shahid's question. So for transplant eligible patient, you told us for a relatively this side of the word, triplet followed by transplant. Transplant ineligible patient, what will be your recommendation then?
So if you look at the transplant ineligible patient, at least in the US, there are two different therapies that is being used right now. One is called the VRD, the Velcade Revlimid and dexamethasone, which is a standard induction. Right now, at least for the both transplant eligible and ineligible, that is one. And the other one is the study that is approved, the regimen that is approved by FDA based on MAIA study, the daratumumab, Revlimid, and dexamethasone. So both of these regimens are equally, kind of approved option and equally important option for those patients. The choice of that depends on, if you ask me, it all depends on right now. There is no clear-cut data on which kind of patients would benefit from which regimen, but particularly I will look at the patient's comorbidities. If patients have neuropathy at baseline, I would rather avoid Velcade. I would rather go to DRD. If the patient has, a lot of comorbidities, and then you worry about, you worry about the kind of a data-based regimen, then you try to go to VRD. If the patient has high-risk cytogenetics, for example, the 414, then I would probably prefer Velcade-based regimen in that, just because we have data with the Velcade and the 414. But both the trials are very important. Of course, the VRD is regimen for transplant ineligible patient is based off the SWOG study, which has one of the longest follow-up, showing the benefit of survival in patients who take VRD versus RD. So that is very powerful study. But what is equally important is also the MAIA study, because MAIA study tries to establish one important concept in myeloma is you don't need the PI in this patient, because DRD versus RD also we have higher rates of MRD negativity, deeper responses, and better progression-free survival. We have to see whether that will translate into better overall survival. But at this point of time, both regimens are equally important. Now, in the context of India and the other part of the world, I'm not sure how. For example, we already talked about data being very expensive and not being able to use. Then you look at the other regimens that are available in this setting. There is one regimen is VMP, which is the one that is approved in the Europe, but now they are doing Dara VMP. Nobody is doing just VMP because Dara VMP is approved. So that could be one option. And the other one is VTD, but rather, in the US, I would probably do, in the US setting, if you just extrapolate that, I would probably just do VRD for the transplant ineligible patient. That probably is the best option if that is available.
Thank you so much for that. Dr. Bhattacharya, your question.
Thank you, sir. I hope I am audible.
Yeah.
Thanks, Dr. Binod, for the nice talk and informations for us. My question is, you were talking about the ctDNA to detect the MRDs. So can you guide us about the practical standpoint about which time should we pick to do the ctDNAs, whether it should be upfront, whether after the first line failure? What is that exact time in the practical scenario we go for the ctDNA testing and to detect the residual disease, or to be specific, the more chances of recurrence in relapse refractory myelomas?
I mean, we really don't know the answer to that question right now, because it's very, you already saw the data is very at infancy. We still have to first validate the value of that ctDNA in a large study and cross-validate that with the MRD based assay. So we don't know whether that's going to hold true. But if everything goes well, let's say I validate that and I saw that this is good, equally, then as you do the MRD assay, instead of doing the MRD, I think you can just do the ctDNA, and after any treatment, you can use that as a prognostic tool. But again, this is also needs to be investigated into the trials as we are doing for the MRD. So there are two-level problem that with the ctDNA right now going into full practice. One, we have to show that is validated or that is equally good as an MRD-based assay, number one. And number two, same as MRD, and at what point and how we can use that as an actionable things, that also needs to be investigated. So it's still, we're very far away from this technology being used in day-to-day practice, but the data is very provocative at this stage, and I hope that in the next 1 or 2 years we will have more answers.
Thank you, sir. Thank you.
Thanks. Dr. Akshay.
Thank you for an excellent talk. I would like to, by Dr. Binod, I would like to ask, what would be the treatment modifications would you make if MRD is positive at the end of induction, consolidation, and maintenance? Would you like to continue the same treatment or modify the treatment?
So that's actually a very relevant question, because we are investigating or we're trying that in different clinical trials right now. For example, I can give you one of the trials that we are planning to do, where we look at the transplant eligible patient and then look at induction with a very effective quadruplet combination. And if they're MRD positive, we are thinking of delaying the, if they're MRD negative, we're thinking of delaying the transplant and looking at sustained MRD negativity with some kind of maintenance. Versus patients who are MRD positive, then they can go to transplant and then see if that kind of translates into superior survival. So you can use, again, it's the trial level question right now. At any time point you can use that. But if you ask me, at all those stages, you can use that as a tool, to make different decisions. For example, the induction can be used to see if you can benefit from added induction or other induction regimen to clear the MRD before the transplant, versus taking them to transplant versus not taking them to transplant if they're MRD negative. And similarly thing with the consolidation, and similar thing with the maintenance. So it's all the different situations that we kind of laid out to you in terms of some of the hypothetical situations that we can use MRD. So these are all the trial level questions are definitely being investigated in different clinical trials. And hopefully in the next 3-4 years, we will have the answer whether using MRD after induction versus consolidation versus maintenance can be a good tool, to benefit these patients.
Thank you, sir.
Thank you. Dr. Bharat.
So thank you very much to Agarwal sir and Dr. Binod for this platform. My question is more the problem which I face in day-to-day practice. I'm a medical oncologist, not a hematologist. So I see, I'm in Hyderabad, where I see a lot of patients coming from northeast zone of India. And many of them, they have background hematological disorders, which could be hemophilia or thrombophilias. So in this situation, so my question goes both ways. If it is a severe hemophilia or moderate hemophilia or symptomatic thrombophilia, how do you change your regimen, anticoagulation, antiplatelets, if you're giving bortezomib-based treatment?
So for bortezomib-based treatment, you don't need any anticoagulation. That is for sure. You don't need to put them in prophylaxis. For Revlimid-based treatment and thalidomide-based treatment, you have to put them in prophylaxis. The minimum you can do is the baby aspirin, the 81 milligram aspirin. That is equally good as the other kind of, at least in our practice, we just do baby aspirin. So at the minimum you can do is that, and I assume, I think that these patients, I have not taken care of any patients with the severe hemophilia with multiple myeloma, but I have one patient with acquired factor IX from myeloma. So in that patient, the myeloma, as we treat the myeloma, the factor IX got better. So that's the difference. So we could use the anticoagulants in those patients. But I would assume the minimum, using this aspirin, baby aspirin should be fine if you are thinking of doing the thalidomide or Revlimid-based regimen.
So even in moderate deficiency or severe deficiency, you will still offer aspirin?
If you are thinking of doing so I can tell you one patient that I had just right now in my practice. She had a history of multiple intracranial hemorrhages. So you can think similar kind of patient.
Yeah.
And the aspirin was completely contraindicated to the patient. Unfortunately, I couldn't offer her Revlimid. So I had to use the CyBody-based regimen. So I avoided Revlimid completely because that, the antiplatelets were contraindicated by our the benign hematologist. So I didn't use the Revlimid or thalidomide at all. And thalidomide we don't use. Revlimid I didn't use at all because we don't want the patients to go into to develop a clot of not using the prophylaxis. So this is very unique and rare situations. You have to make the decision. Of course, you want to give the patient the best treatment, which is a triplet using PI and IMiD. But if you are thinking of Velcade-based only regimen, you don't have to worry about prophylaxis. You have to think of prophylaxis only when you are using the immunomodulator-based treatment. And depending on the severity of the condition, and then the context of the patient, you probably have to change the treatment.
Thank you.
Thank you very much.
Thank you. Dr. Alkesh.
Thank you, Agarwal, sir. Am I audible, sir?
Yeah.
Yeah. Most of the questions answer I received during the presentation. Some of the questions are there. Which comorbidities work as an obstacle to achieve the good negative MRD value? Which are the comorbidities that work as obstacles to achieve the good negative MRD values, sir?
So if you look at myeloma, it's very clearly defined in the transplant eligible and ineligible patient population. And that is based on a number of factors, but patient comorbidities will definitely play into role as one of the factors in deciding whether the patient going to transplant or that cannot go into transplant. So if you just look at the patients who are transplant eligible, since they can get into transplant, the chance of getting into higher MRD rates are higher. So that could be one of the things. And in that case, the comorbidities would include like your heart condition, your lung condition, those are the two major comorbidities I would think, because when you look at the patients with who are dialysis or who are kidney failure, you can still offer them the transplant-based treatment. Now, to answer your question, I think it all depends on what kind of regimen you are thinking about. And then if you're thinking of doublet versus triplet, so the patient has some bad comorbidity that you cannot use Velcade-based regimen, for example, bad neuropathy, then that could be one thing related to that treatment. So the other comorbidity, I think, has to do with what kind of drug you are using. For example, if you're thinking of doing carfilzomib-based treatment, then of course the cardiac comorbidities will play into role in those patients. Similarly, if you're thinking of the lenalidomide-based treatment, then you have to think of renal comorbidities, renal function as one of the comorbidities in deciding and whether you can do the full dose and so on and so forth. Though you can still adjust the dose, but there is always a reluctance to use the full dose Revlimid in those patients. So the patients who are going for transplant-based therapy, who we know that they are gonna get the high rates of the MRD negativity, the cardiac and lung and the pulmonary functions that become kind of one of the important point, and their overall functional status. But otherwise, I think it depends on what drug you are trying to use and combine. That particular drug, is related to that comorbidity might might be a kind of limiting factor in using those drugs, and hence to get the higher rates of MRD negativity.
Thank you, Alkesh. Dr. Ramesh.
Good evening, sir, for giving me this opportunity to participate in this platform. Sir, I have two questions. First is, how common is extramedullary relapse in patients who are MRD negative?
That's not that very common, actually. Not that very common. I can't tell you the exact percentage, but patients who are MRD negativity, I have not seen. I have seen in non-secretory. So just MRD negativity. If somebody has secretory disease and MRD negativity, the chances that they developed the extramedullary disease is very less. But the patients, let's say the patient is relapsing and the relapse pattern is more non-secretory kind of pattern of the relapse, where if you try to do MRD negativity, they have no disease in the marrow, and then they are MRD negative, but they may present with the extramedullary disease. So it's rare, but it does happen. But when you're looking at a patient who does have extramedullary disease as well, and also has a bone marrow based disease, and if you just look at one bone marrow assessment and then say this is MRD negative, you need to take into account of the extramedullary disease as well to monitor the disease and to say that this is the response that the patient has achieved. So in the early setting, when the patients present with both extramedullary disease and medullary disease, if you achieve MRD negativity, it's likely that you're gonna have this resolution of the extramedullary disease as well. But in the later setting, once the patient gets into non-secretory kind of relapses, you are likely to see more of those in the latest stage of relapses, more extramedullary diseases and less secretory disease and less marrow disease. And when you try to do a marrow on those patients, you may not see them disease and MRD, and could be MRD negative, but still could have disease and outside the bone marrow.
Okay, sir. Sir, my next question is conventional 10-color flow is reliable when compared to multi-parametric flow cytometry, next generation flow or next generation sequencing?
Yes, there are a lot of institutions that do the conventional flow, and then they try to validate that with the next generation flow. In the US itself, there are like few centers that do that, but they're color probe, and they have validated that sensitivity with the next gen flow. In our practice, we do the flow, but the sensitivity, we still can get the sensitivity 10 to the power minus 6, but they require more additional personnel, so they have just limited to 10 to the power minus 4. So for the higher sensitivity, we have been using the next gen sequencing method, because there you can directly get the data from the 10 to the power minus 6. But to answer your question, yes, you should be able to get as long as you are getting the similar level of sensitivity, which you can get from the flow cytometry as well, you should be able to be, you should be fine.
Okay, sir. Thank you, sir.
Thank you, Ramesh. Dr. Kunal.
Good evening to all. Thank you, Dr. Agarwal, sir. And thank you, Dr. Binod, sir, for enriching us. Most of my questions have already solved, but I have few queries. Like at your center, do you follow imaging and bone marrow MRD both, or the bone marrow MRD alone for monitoring the patients? And what implication did it created for your patients in practical setting?
Mm-hmm. So, when you look at the MRD as an actionable tool, we still are investigating in the clinical trials. So we really don't know, we could get the MRD assay or MRD value for those patients, but if we don't know what to do with that value, we don't act on it, then it might not be important for the patient. So in the US, if you look at in general, most of the patients get MRD assay, and several of the academic institutions do the MRD after transplant, after treatment, and to get an assessment of the prognosis of those patients. In our practice, we try to do in selected cases. For example, the standard risk patients, we try to do in patients like, for example, somebody in maintenance for a long time and have good disease response and want to know about whether they could potentially stop the drug, or can go on to the continue the maintenance. There is one group. But most commonly that we do that is for the high risk patients. For example, somebody is a high risk cytogenetics, have transplant done, and then in that setting, I usually do those patients uniformly for all patients, both MRD by bone marrow and also the PET imaging, and then try to give them a prognostic answer that you're likely to do better. For example, recently I saw a patient who was 43-year-old female with a very high risk myeloma, and just had a baby, 11 months baby. She got diagnosed, and then we got DARA VRD induction transplant, and then after transplant I made sure that I get the MRD assessment done for those patients, for that patient to talk about the prognosis, and number two, also to act on it. So for example, to decide on maintenance. So if somebody is still MRD positive and high risk, and I would like to do a little bit more than just Revlimid maintenance or just Velcade maintenance, to try to do more. Again, this is not based off any data. This is just based off the fact that MRD can be a very good prognostic marker and can mitigate the high risk, kind of poor prognosis of the high risk marker if they are MRD negative in high risk patients. So for high risk patients, yes, I do uniformly for both the MRD by bone marrow and by PET imaging, but a standard risk and select basis until we have the data from the trials.
Okay. And in your second case, if the patient becomes MRD positive, then what will be your approach?
So this is that we had investigated in the master trial, which we included, enroll about 123 patients. Nothing we have done. We're just looking at this MRD resurgence of these patients, and that data will guide us how these patients behave with this MRD resurgence. So we're right now investigating and analyzing the data very closely and following these patients. To answer your question, we don't do anything. We just follow them closely.
Okay. Thank you.
Thank you, Dr. Kunal. Dr. Giripunja.
Good evening, everyone. So, sir, my question is, like, if the patient has achieved MRD negativity already, like the standard risk, especially, like if the patient is high risk, definitely we take them upfront for transplant. So, is there any role of avoiding transplant in like standard risk MRD negative post induction?
Yeah, I mean that's that we are hoping to get that answer, because now we have all good drugs. For example, you saw the DARA VRD, yes. MRD negativity rate is very high, DARA KRD is very high, and we are now talking about the CAR T and bispecific antibodies therapy, which even like in the CAR T, if you look at the data, I mean, even those heavily treated patients, you are achieving like 80%, 70% MRD negativity, very unprecedented MRD negativity rates. So that brings up the question that you just asked, like whether we can avoid some more intensive therapy in those patients who we know they're most likely gonna sustain that MRD negativity. So that is the trial level question, which we are already doing it and investigating it. And if you ask me hypothetically, yes, that should be the thing, that we should use MRD by both bone marrow and the imaging based MRD, and then probably avoid this more intense treatment in the patients who don't need those treatments. But in the standard of care, we don't do that right now. We just go with the with the standard approach for these patients as well.
And in smoldering multiple myeloma, sir, high risk SMM who require treatment, like what is the role of MRD? In one of your trials also, you said 15 patients were smoldering myeloma, like where you said NGS was better than multicolor flow cytometry.
So high risk, again, high risk smoldering myeloma, right now the question is still debatable whether they need the treatment or no. So they are investigating that in the clinical trials. We just completed a trial where we used very intensive approach in an attempt to cure the disease in high risk smoldering myeloma. And the debate is ongoing whether you need to cure or you need to control, whether you can do like limited treatment, like for example, the ECOG study that you looked at, RD versus, versus observation. Those kind of treatment just to delay the progression to myeloma. In that, if you're looking at that, you may not get to have big MRD. But if you are trying to cure the disease, for example, our trial, which we are a part of, we did the DARA KRD induction, DARA KRD consolidation, and DARA Rev maintenance for total of 2 years. And there, the primary endpoint is MRD negativity. So if you are trying to achieve a cure in smoldering myeloma, then MRD negativity becomes very, very important endpoint. Because without achieving MRD negativity, I don't think you can call it as a potential cure, or potentially, you can say that you have cleared the disease. So those kind of trials we just completed the study. So we'll have some data coming at ASCO next year, and we'll see the long-term follow-up of these patients to see how much they can sustain the MRD. But that's again, depending on the philosophy of the treatment, what you want to do for those patients. If you're doing for cure philosophy of the smoldering myeloma, which I think, with I think a lot of trials are doing, I think MRD negativity becomes a very important endpoint for those patients.
Thank you. Dr. Binod, we have some questions collected from the emails. Can I put those questions to you?
Yeah.
One question is, what will be your indication to use carfilzomib upfront in myeloma?
So, there are two things. One is the carfilzomib is very effective drug, very important drug in myeloma, and of course, been approved in the relapsed refractory setting after one line of therapy in combination, and also does just with dexamethasone only. Now, in frontline setting, using carfilzomib there are two main things that come up. One, whether it can be used as a good induction regimen compared to Velcade-based regimen, and that question has not been answered. Number two is, can you use that in high-risk patients? The second question. Now, the first question, carfilzomib-based regimen versus Velcade-based regimen, because they are the same PI class. So the part of that question was answered in a trial called Endurance Trial, which is a plenary paper at ASCO last year in 2020, where they looked at the KRD versus VRD with patients who had no immediate upfront intent for transplant. So the patients can delay the transplant or don't go to transplant. What that clearly showed is that KRD is equivalent to VRD. And in terms of the comorbidities, patients with K had higher cardiac comorbidities and V has higher peripheral neuropathy and discontinuation rate. So the question is they are equivalent, okay? But that doesn't answer the question of induction treatment, whether you can use KRD versus VRD induction in high-risk patients. Now, if you look at the Forte trial in that setting, KRD followed by transplant or KRD just by itself has given very high rates of MRD negativity, much higher than what VRD transplant gave to in IFM trial. So the debate is still there in terms of whether KRD can be used in place of VRD in terms of induction, and whether it can be used in selected patient population. So the practice is very variable on who you ask. If you ask me, I use KRD in patients with high-risk cytogenetics compared to VRD, or patients who did not respond well to the VRD induction. After 2 cycles, they have suboptimal response, less than partial response. For example, the first patient, if you look at the first patient, that discussion that we had, she had like 4 cycles of VRD and the patient still had suboptimal response, less than partial response. So I just gave 2 cycles of KRD and the patient had partial response and better, which we knew that this probably is better than just having less than partial response. So in that kind of cases, I think I do. It's very variable in practice. At this point of time, we don't have answer on the induction regimen question. We do have an answer in the initial treatment with no intent for transplant. Both are equivalent. So you have to choose based on the comorbidities of the patient. I mean, the cardiac comorbidity, you want to avoid K and vice versa.
Thank you so much. The next question is, are you looking at 1Q amplification to risk stratify the patients?
1Q amplification is one of the high-risk cytogenetic. Yes, I look at that and include that as a high-risk cytogenetic. So when I decide on induction or maintenance, and I use that as a high-risk marker and decide what to do for maintenance. For example, if 1Q amplification is there, I would do triplet maintenance or at least a doublet maintenance to the Velcade Revlimid or carfilzomib Revlimid versus just Revlimid in those patients.
Right. The next question is between the various anti-CD38 monoclonals. DARA remains supreme or there is a challenge?
I mean, if you just look at it's difficult to compare the cross-trial comparisons. But if you look at just the same patient population, for example, the 1 to 3 prior lines of therapy, where DARA is combined with the carfilzomib in DARA KD, which is a Candor study, and compared to KD, that is one trial. And then there is another monoclonal antibody, isatuximab, is combined with carfilzomib with ISA-KD versus KD. That is called IKEMA study. If you look at the response rate, I mean, they are equally same. They're not inferior. They're pretty good. The higher response rate, the better PFS. So if you ask me, both are same in terms of efficacy. Now the question is, the DARA came very early on, has already taken a lot of kind of influence on that, and then it's very popular, and so people know about it more. But more importantly, DARA became subcutaneous administration in 2 to 3 years before, and that made a huge deal in the patient. Patient who had to sit in the chair time of about 6-7 hours now can get this drug in in less than half an hour and get out of the clinic. So that makes the use important, and it's definitely a kind of transformative for patient and for us as well. So I think if you have to choose that, I would choose data over other monoclonal antibodies just because the ease of administration. But comparing head to head, even in the absence of data, just looking at roughly cross-trial comparison, I would say the efficacy is pretty much the same at this point in time.
Thank you. The other question is about the CAR T therapy. What is the median progression-free survival by present CAR T therapy available for myeloma?
So right now, it depends on what construct you are talking about. So at the one that is approved, called Abecma, is the only one approved CAR T therapy right now. So the median PFS for these patients is about 8.6 months. They had a median of 6 prior lines of therapy, including almost 80% triple refractory patient. So that is pretty impressive for the patient population that you selected. But if you have to choose, I would probably choose the other one, the cilta-cel, which is based on the CARTITUDE-1 study. And they had also similar lines of treatment, 6 prior lines of treatment, similarly heavily treated patient population. The median PFS in these patients is about 22 months. And if you look at the patients who have stringent complete response, where 80% of them had stringent complete response, their median PFS was not even reached. So this is very impressive activity. But both are equally good. I mean, both are very good because the patient population, the other choices are not that great as compared to those. But if you have to choose in terms of efficacy, I would rather choose cilta-cel just because of this impressive response rate, and that translated into higher MRD and response rate, MRD negativity rates, and also the higher PFS.
Right. The other question is regarding comparing bispecifics with CAR T therapy. How do you select as the modality of treatment in a refractory case?
I mean, there's no right or wrong answer. I think both are equally important. If you look at the responses, biospecifics, there are unique advantages to the biospecifics being off-the-shelf therapy, can be given right away to the patient. And then potentially less CRS and ICANS as compared to the CAR T. So that is a unique advantage. Maybe highly comorbid patients can take that. But in terms of efficacy-wise, of course, CAR T has very other unique advantage of one and done approach that the patient don't need any other treatment after that. So it's very important in myeloma, gives you a lot of quality of life, potentially cost-effective. We don't know that, but potentially cost because you're not getting any therapy afterwards. So it's at this point of time, they have value. Both has value in treating patients with myeloma. There are some unique attributes that would potentially favor one patient, one group versus other. And we have to see whether how it's going to pan out because we don't have any bispecifics approved in the myeloma as of yet. But looking at the responses, they look pretty impressive as well. So it's difficult to answer the questions right now.
The last question I have is, how do you follow up a patient who has started showing relapse at biochemical level? M-band has started coming up, or FLC started getting altered. Patient is asymptomatic. There is no CRAB. There are no other clinical features.
So biochemical progression is a very unique population of patient that unfortunately have any guidance on how to manage those patients. Because before we didn't have a lot of good therapy, so people need to wait till the patient progress and get clinical relapse. But now that is not the case. It's going back to the same thing of MRD resurgence. When you look at the MRD resurgence, what to do with those patients? We don't have any data and we don't act on it. But biochemical relapse, at least you have the disease that is progressing. And two things that help me guide: one is how fast their relapse is. If they relapse, the velocity of the relapse is very fast, that is, they are doubling their M protein or FLC in every month, then I think the writing is in the wall. I mean, if you wait too much, I think you're going to have a problem. You're going to have the patient the problem. And it's not that we don't have good therapies options. We have so many options available. We can offer it to them and to prevent that. But if somebody has a low-level disease progressing very slowly, I have a patient which I have watched for like 2 years. The disease is slowly growing. So it all depends on the tempo of the disease, and then we decide to treat based on that. And some argue that they are going to relapse anyway. Why to wait for that? But this is a kind of data-free zone that we can just very more individualized decision making at this point of time.
Dr. Giripunja, you have a question?
Yes, sir. Sir, in your setting, like what are the minimal markers you do for flow, like for MRD? is there anything like set of markers like which we definitely need to do, like in a resource constraint setting like ours? What are the minimal markers we need to look at?
I don't know all the specific markers that they do. They do the 8-color flow here at our place. I don't have that answer, but it all depends on the sensitivity of your assay. If, sensitivity is, the better sensitivity, the deeper sensitivity is always better. So in the constant setting, whatever the marker that could give you the highest level of sensitivity, I think I would suggest, I would recommend using it. Unfortunately, I don't have all the markers that what did. I can share that with you. I have that in the writing somewhere, but I don't remember what all those markers are.
Sure, sir. Sure, sir. Thanks.
One question has come up in the question box about what's your protocol for treating plasma cell leukemia?
So for the plasma cell leukemia, a very challenging disease. What we do is we do induction with either VDT pace or KD pace induction. And if the patients have some comorbidities, cannot handle those intensive regimen, then we tend to do DARA KRD. And then after that, to go to auto transplant for sure. In young patients, auto and referral for allo transplant. Or in other patients, I try to do tandem auto depending on how the response to the first transplant, and then go on to maintenance for sure, VRD maintenance or KRD maintenance for those patients. So I had a patient who was 74-year-old male who had a very bad plasma cell leukemia, presented with a pancytopenia. So that patient, I did a DARA KRD and then a transplant, and then put him on KRD maintenance. And then now he's going to and then he did have a disease control for 2 years. Now he's relapsing, so he's going to kind of a clinical trial. So that is one way I was treating. The other patients, who is 48-year-old female who had primary plasma cell leukemia, I treated as VRD pace, and then transplant, and then refer for allogenic transplant. So it all depends on the age of the patient. There is of course no any defined guidance, and because it's a very rare entity, and there is no large scale studies to guide the treatment, but but intensive treatment, transplant followed by intensive maintenance at the minimum.
When you offer CAR-T, the disease has to be brought down, some kind of control has to be achieved, or they could directly go? They could directly go. There is no, it all depends. If they can wait, they can directly go. Having said that, in some of the studies, it showed that if you have a very high disease burden, your chance of getting CRS, higher grade CRS and eye cancer is higher if you have high disease burden. So enhanced bridging is recommended in those patients. They can wait and get to the CAR-T, because if you don't do anything, they may not be able to get the CAR-T, which is a big problem. But if you can do a bridging and can hold them to get the CAR-T, they can probably get. So I think that's for the reason that I think bridging is probably recommended in high disease burden. But if they can wait, so I have a patient who's going to CAR-T clinical trials. She's essentially asymptomatic, but she has a very high disease burden. And I'm giving a little bit of bridging because I don't want her to go into like severe CRS and all those stuff. But she can actually wait to get the CAR-T next month. So. How impressed are you with the results of venetoclax with PI in 11-14 translocation relapsed patients? I mean, so the one data that we have is from the Bellini trial. Of course, we saw that the subgroup did benefit. And there's a phase 3 study that was just published yesterday by my colleague Luciano. And that showed that overall there is 70-80% response rate, which is pretty impressive. But there's a small scale study that didn't really see the difference between 11-14 versus non-11-14. It is impressive, but it has to be compared to the standard of care available for for the standard. If you compare with the other standard of care patients, but biologically, I think it should work. Right now it's a little bit early to say, in this 11-14. More questions come up. Is a lab-based question again. If the patient has been treated with DARA, then while gating for flow, CD38 may be lost. So do you have different strategy for gating?
Yeah, I think there is a strategy. You have to let the pathologist know that the patient got DARA, so they do some kind of modification there. I don't know the exact mechanism how they do it, but we always tell the patient if you are doing the DARA-based, I mean the flow-based MRD, that we always tell the pathologist this patient has received daratumumab. But there is a mechanism, yes.
Thank you. So those were the questions through email and in the question box. Faculty here, any other question you want to trouble Dr. Binod with?
Yeah, can I ask one question, sir?
Yeah, Abdul, go ahead.
Yeah. So I think now as we are talking about more about MRD and more deeper response. So are we reaching an era that we can say that myeloma is curable, at least in some set of patients?
Potentially, yes. Again, we need look at in large scale of the patients. It is quite possible with these new therapies, you are able to achieve a deeper response, and more importantly, you can potentially cure this. Like right now, if you look at it, triplet induction transplant, you can provide long-term benefit or long-term disease control for about less than 10% of the patients. But that percent of the patients, I think, is expanding now with these new therapies and then new modality of treatment. So yes, I think we are at least providing a long-term disease control in majority of the patients. And with the CAR-T and with immunotherapy coming up, I'm pretty hopeful that that percentage of the patients will go up. I think the unmet need of the patients, unmet need population like a high risk, old patients like comorbid patients where they cannot get all this intensive treatment. And that still remains. I think that is going to be an ongoing challenge. But the standard risk young patients, I think it's most, and with the MRD as an endpoint, I think we can potentially provide long-term control for those patients and maybe even cure.
Thank you, Dr. Shahid. Before I hand over to Mr. Sumit Madan for official vote of thanks on my behalf, on behalf of Mumbai Hematology Group, Dr. Binod, we are extremely grateful to you. You spared your 2 very valuable hours and answered a lot of questions. The faculty here was very young faculty. Some of them are doing their DM hematology and medical oncology. Others have just come out and are senior fellows or residents. So they had their difficulties and you very patiently answered everything. Extremely grateful to you. And thanks to the faculty here for you to come and interact for 2 hours. You made this very lively. Over to Mr. Sumit Madan for the vote of thanks.
We thank Mumbai Hematology Group and Dr. B Agarwal for providing us this opportunity to participate in this virtual academic feast. I would also like to thank Dr. Binod for delivering a lucid and insightful talk and making the entire discussion so lively. I take this opportunity to thank all respected faculty members and delegates for sparing their precious time and joining us for this program today evening. Thank you everyone and good night.
Good night.
Thank you, everybody.
A good day to Dr. Binod. Bye-bye.
Good day, sir.